Hey guys, welcome and welcome back to my channel. This is Dr. Prasanjit Das, currently JR2 in the Department of Pharmacology, AIMS Kalyani, and I am back with one of my seminars. So without wasting any time further, let's get into today's topic. So in today's seminar, I am going to discuss the topic that is recent advances in hypertension therapeutics. So I have collected the information from 2015 to 2024. So let's discuss this topic. So we will be discussing this under the following headings, that is the introduction, then the WHO guidelines for the management of hypertension, which is basically the WHO 2021 guidelines, and then the Indian scenario, that is the guidelines in case of Indian scenario. So here I have taken the reference from 2016 guidelines from the Ministry of Health and Family Welfare. So these are subjected to change in the upcoming future. So the guidelines keep on changing. So as you can understand, these two topics are very dynamic in nature, so they keep on changing. Then we have aprocitentan, the drug which got approved by US FDA in the year 2024 for the management of hypertension. And finally, some of the advances in management of hypertension. So first, coming to the introduction. So as we know that hypertension is basically increased or raised blood pressure, and it is a condition which affects the blood vessels basically. So here the blood vessels are having a persistently raised pressure, so which is basically more than equal to 140/90 mmHg. That is 140 is the systolic blood pressure and 90 is the diastolic blood pressure, and it is associated with several other comorbidities like acute coronary syndrome, then stroke and heart failure. So it is imperative that if we have adequate BP control, then it reduces the incidence of these comorbidities, that is acute coronary syndrome, then stroke and heart failure, by 20 to 25%, 30 to 35% and 50% respectively. That is the reason why we need to manage hypertension very promptly, because it decreases the chances of several comorbidities like acute coronary syndrome, which is very severe condition. Then we have stroke, heart failure and all those things. Now let's get into the guidelines for the management of hypertension. So first we will begin with the WHO guidelines, that is World Health Organization guidelines. So first part, that is what is the blood pressure threshold for initiation of a pharmacological treatment for hypertension. So under this we are having three categories. So WHO recommends initiation of the pharmacological antihypertensive treatment for individuals who are having confirmed diagnosis of hypertension, that is systolic blood pressure more than equal to 140 mmHg or diastolic blood pressure more than equal to 90 mmHg. And WHO also recommends pharmacological antihypertensive treatment for those individuals who are having existing cardiovascular disease, okay, but they are not yet diagnosed with hypertension, but they are having existing cardiovascular disease plus their systolic blood pressure is in the range of 130 to 139 mmHg. So in that case also we will start the pharmacological treatment. Then WHO also suggests pharmacological antihypertensive treatment for individuals who are not having any cardiovascular disease right now, and they are not even diagnosed with hypertension, but they are having high cardiovascular risk or other comorbidities like diabetes mellitus or chronic kidney disease, and the systolic blood pressure is in the range of 130 to 139 mmHg. So there are three criteria when we had to start the pharmacological treatment with antihypertensive medication. First, if it is diagnosed, that is diagnosis of hypertension is done, that is more than equal to 140/90 mmHg, and two other cases where the diagnosis is not yet done, but the systolic blood pressure is in the range of 130 to 139 in both the cases, and in one case we have a cardiovascular disease already present, and in other cases we are having risk factors like high risk of cardiovascular disease, then diabetes mellitus and chronic kidney disease. So in both these cases again we can start antihypertensive treatment, that is antihypertensive medications, basically the pharmacological management of hypertension. Now let's get into the next point, that is the recommendation of laboratory testing. So whenever we are starting this pharmacological therapy for hypertension, WHO suggests that we need to do tests to screen for any comorbidities and to rule out secondary hypertension. But this test is to be done only when it is not delaying the start of the treatment. So we are going to do the test to find the comorbidities present, and we have to find out whether this is a primary hypertension, that is which is not having any cause, that is basically idiopathic and essential hypertension, whereas secondary hypertension is due to some already existing disease like diabetes mellitus, chronic kidney disease, which can also lead to hypertension. Now, recommendation on the drugs which are to be used as the first line agents for the management of hypertension. So here we are having only three categories which are usually used as the first line agents. First is thiazide and thiazide like agent, which are basically the diuretics. Then we have angiotensin converting enzyme inhibitors or angiotensin receptor blockers, that is ARBs. So ARBs are used when angiotensin converting enzyme inhibitors are contraindicated, that is they lead to some of the adverse effects like angioedema or cough. In that case we can use ARBs, but usually we start with ACE inhibitors because it is less costly, whereas in case of ARB they are comparatively costlier than ACE inhibitors. Then we have long-acting dihydropyridine calcium channel blockers. So these are the three classes of drugs which can be used as the first-line agent, and usually in case of management of hypertension, we start with a combination of drugs. So these three drugs can be combined also. But these are the drugs which are preferred as the first-line agents for the management of hypertension. Now, combination therapy. So we can start the individual in a single pill combination, that is a drug which is having a combination of multiple antihypertensive agents. So basically it is a fixed dose combination. And what is the advantage of using this fixed dose combination? This is because it improves the adherence and compliance to the patient. So there is adherence and persistence of the treatment is there. So since the patient has to take one pill, so the patient will not have much hesitation in taking the pills, and as a result there will be better control and better compliance to the treatment, leading to better outcome in hypertension treatment. So here also we are going to use the three classes which I have already mentioned, that is thiazides, then calcium channel blockers, angiotensin converting enzyme inhibitors or angiotensin receptor blockers as combinations. So you can see here that is diuretics, then we have ACE inhibitors or ARBs, then we have the CCBs, that is calcium channel blockers. Now, what is the target blood pressure? That is, what is our therapeutic endpoint? So whenever we are starting the hypertensive treatment, that is antihypertensive treatment, we are targeting for the blood pressure to be less than 140/90 mmHg in all the patients of hypertension without any comorbidities. That is, hypertension is there but no other comorbidities. In that case, our target will be to reach below 140/90 mmHg. But in case the individual is having hypertension plus a known cardiovascular disease, then in that case, our goal will be to reach a systolic blood pressure which is less than 130 mmHg. And similarly, the third case which we have mentioned earlier, that is the criteria for starting the pharmacological treatment. Similarly, here if the individual is having hypertension, along with that, if they have cardiovascular disease risk or diabetes mellitus or chronic kidney disease, in that case also our goal will be to reach a systolic blood pressure which is less than 130 mmHg. So if no comorbidities, then in that case we have to reach a blood pressure of less than 140/90. If there is the presence of a confirmed cardiovascular disease, then in that case we need to reach a systolic blood pressure less than 130 mmHg. And if the individual is having hypertension but not a cardiovascular disease, but a high risk for a cardiovascular disease or diabetes mellitus or chronic kidney disease like comorbidities, in that case also we have to reach a systolic blood pressure which is less than 130 mmHg. So these are the therapeutic endpoints which we are trying to achieve as per the WHO guidelines 2021. Now, the frequency of reassessment, that is when we are doing the reassessment of the individual, that is we are checking the blood pressure in the frequent visits. So WHO suggests monthly follow-up after the initiation or if there is any change in the antihypertensive medications till the point we are reaching the therapeutic endpoint, that is the target which we have already discussed. And suppose the individual is having well-controlled blood pressure, then in that case we will do follow-up in every 3 to 6 months. That is, the blood pressure is under control. In that case, we will do follow-up we will do follow-up in every 3 to 6 months. Or else, we have to do monthly follow-up till the time the target blood pressure is reached. Now, coming to the Indian scenario. So, patients with hypertension, according to this Indian scenario, that is 2016 guidelines by Ministry of Health and Family Welfare, the hypertension is classified into the following categories. So we have grade 1 hypertension, grade 2 hypertension, grade 3 hypertension, isolated systolic hypertension, hypertensive urgency, and then hypertensive emergency. So what is grade 1 hypertension? So grade 1 hypertension is systolic blood pressure of 140 to 159 mmHg and or diastolic blood pressure from 90 to 99 mmHg. Then grade 2 hypertension, it is 160 to 179 systolic blood pressure, then 100 to 109 mmHg of diastolic blood pressure. Then we have grade 3 hypertension where systolic blood pressure is 180 mmHg or above and or diastolic blood pressure is 110 mmHg or above. Then we have isolated systolic hypertension. So from the term itself, it is clear here there will be increase in the systolic blood pressure, but the diastolic blood pressure will remain normal. So here systolic blood pressure is more than 140 mmHg, but the diastolic blood pressure is less than 90 mmHg, which is normal. Then we have hypertensive emergency. So here systolic blood pressure will be more than 180 mmHg and diastolic blood pressure will be more than 120 mmHg, but the patient will be asymptomatic. That is, they will not have the symptoms, but the pressure will be high. So basically this needs to be treated promptly. And then we have the hypertensive emergency, which is a grave situation where we have severe hypertension along with some other issues like the end organ damages. Basically in cardiac case, we are in cardiac problem, we are having acute left ventricular failure. Then in neurological condition, that is we are having the hypertensive encephalopathy, plus we will also get renal dysfunction. So it is basically increase in the hypertension leading to end organ failures, which can be manifested as acute left ventricular failure. Then if the CNS is involved, it can result in hypertensive encephalopathy, then renal dysfunction. So all this will be present. So this is basically a medical emergency and it needs adequate treatment at a proper time. So this is about the classification of hypertension in the Indian scenario. Now let's discuss the indications for starting the drug therapy in Indian scenario. So drug therapy is indicated in patients with grade 1 hypertension. So mind this word, there is grade 1 hypertension with any signs of target organ damage. That is, if we see left ventricular hypertrophy on electrocardiogram, then if we see proteinuria on urinalysis, if there is hypertensive retinopathy on fundus examination, then we will do the drug therapy, then we will start the drug therapy. Or else, if the patient is having diabetes along with grade 1 hypertension, or if chronic kidney disease along with grade 1 hypertension, if there is any evidence of coronary artery disease or congestive heart failure and cerebrovascular disease along with grade 1 hypertension, then also we are going to start the drug therapy. And if patients are having 3 or more than 3 risk factors, including the age, that is advanced age, then gender, then smoking, obesity, dyslipidemia, diabetes, impaired fasting glucose, family history of premature coronary artery disease. In all these cases, along with grade 1 hypertension, we need to start the drug therapy. Then continuing with it, drug therapy in patients with grade 1 hypertension, which is uncomplicated by any organ damage. That is, without any comorbidities like diabetes mellitus or clinical cardiovascular disease. In that case, first we will try the non-pharmacological therapy, that is basically the lifestyle modifications for the first 1 to 3 months. That is, trial of 1 to 3 months of lifestyle modifications is to be done, and then if it is not getting control, then we will start the drug therapy. Okay, so this is grade 1 hypertension, which is not complicated by any organ damage, not having any comorbidities like diabetes, not having any cardiovascular disease or risk. Then drug therapy is indicated in all the patients with grade 2 and grade 3 hypertension, and usually it has to be combined along with the lifestyle modifications like weight reduction, then reducing the intake of sodium in the diet, taking the diet which is rich in fruits, vegetables, fibers, etc. Now coming to the goals in case of management in the Indian scenario, like we have discussed the therapeutic endpoints according to WHO guidelines, which was like less than 140 and 90, that is systolic blood pressure and diastolic blood pressure, when there was no comorbidities. But if the hypertension is along with a cardiovascular disease, that is known cardiovascular disease, or with a high risk of cardiovascular disease along with diabetes mellitus or chronic kidney disease, then in that case we need to reach a systolic blood pressure which is less than 130 mm per Hg. Similarly, we are going to discuss it for the Indian scenario. So current target for Indian scenario, it is for under 80 years of age, we need to reach a systolic blood pressure which is less than 140 mmHg and diastolic blood pressure which is less than 90 mmHg. So very much similar to the WHO guidelines. Then if the patient is above 80 years or 80 years or older, then in that case systolic blood pressure should be 150 mmHg or less than that, and diastolic blood pressure should be 90 mmHg or less than that. Then according to a trial, that is sprint trial, which was done in non-diabetic population at high cardiovascular risk, it was shown that reduction in the cardiovascular mortality was seen in the patients where the target BP to be achieved was less than 120 mmHg systolic blood pressure and less than 80 mmHg diastolic blood pressure. But when we tried to achieve this, it led to increase in the frequency of the serious adverse events and also increase in the serum creatinine. So based on this study, we cannot say that if we are setting a target which is lower, that is a lower blood pressure target, it will be better for the patient, because it increases the chances of adverse effects which can occur because of these antihypertensive medications. So this was basically about the SPRINT trial. Now continuing with the management, there is a preferred management. So here you can see the different types, that is different cases. Basically, either you can have hypertension or hypertension with the comorbidities. So what are the drugs which are preferred as the first line agents? Then what is the second drug to be added to it if it is not getting controlled by the first line agent? Then the third drug to be added to it if it is not getting controlled even with the combination of the first and the second line agents. So we are having isolated systolic hypertension, as I've already mentioned. So here the first line drug will be calcium channel blocker or thiazide diuretic. So if it is not getting controlled with it, then we will add AC inhibitor. Suppose if it is not getting controlled, then the combination will be a thiazide diuretic, then AC inhibitor and calcium channel blocker. Then we have hypertension and diabetes. So in that case, initially we will start with AC inhibitor. Suppose if the individuals, wherever we are saying AC inhibitor, if the individual is not tolerating AC inhibitors because of its adverse effects like cough and angioedema, then instead of AC inhibitors, we are going to use angiotensin receptor blockers. Then suppose if it is not getting controlled with AC inhibitors, then we will add CCB, that is calcium channel blocker, or thiazide diuretic. And finally, if this combination is also not working, then we will use a combination of 3 drugs, that is AC inhibitors plus CCB plus thiazide diuretics. Similarly, you can see in case of hypertension and chronic kidney disease, here also the third line treatment, that is the final treatment will be AC inhibitor plus CCB plus thiazide diuretics. So this is usually seen in most of the cases. Now, if we have a hypertension case along with previous myocardial infarction, that is MI, then in the first line agent we can prefer AC inhibitors, or we can also use beta blockers. Then in second line agent we can use calcium channel blockers or diuretics. Then in case of hypertension associated with heart failure, we can use diuretics as the first line agent or the AC inhibitor. Then in second line agent we can add beta blocker, and in the third line agent we can add spironolactone also. And next is the hypertension with associated previous stroke. So in that case also we are going to follow the same thing, that is thiazide, that is diuretic plus AC inhibitors plus CCB. So this is basically the workflow for management of different types of cases, that is hypertension associated with different comorbidities as per the Indian scenario. Now coming to the drug which got approved by US FDA in the year 2024 for the management of hypertension, that is aprocitentan. So it got approved in the year 2024, that is 19th March, for management of hypertension. So what is aprocitentan, and let's discuss about aprocitentan in detail, because it is one of the recent drug which is being used for management of hypertension. So what is the mechanism of action of aprocitentan? So aprocitentan is basically an endothelin receptor antagonist, that is ERA, which inhibits the binding of endothelin, that is endothelin 1, to ETA and ETB receptors, that is endothelin receptor A, then endothelin receptor B. Okay, so endothelin A receptor and endothelin B receptors. So it prevents the binding of endothelin to its endothelin receptors, that is endothelin 1 is not binding to endothelin receptor, and this endothelin 1, when it binds to its receptors, that is endothelin A and endothelin B receptor, it mediates a variety of disadvantageous effects, like it causes vasoconstriction, fibrosis, cell proliferation and inflammation, which leads to hypertension. So that is what we are targeting here. So in hypertension, endothelin 1 can cause endothelial dysfunction, as you can see here, endothelial dysfunction, then vessel thickening can occur, vascular hypertrophy can occur, remodeling, and it also causes sympathetic activation and increased aldosterone synthesis, which leads to sodium and water retention, which also leads to increased BP. So by preventing endothelin 1 to bind to its receptors, we are targeting all these things, and as a result, this gives the antihypertensive effect of aprocitentan. Now let's discuss about the indications and usage of aprocitentan. So aprocitentan is also known as Trivio. So this Trivio is basically the brand name for aprocitentan. It is used, that is, it is approved to be used in combination with other antihypertensive drugs. That is, if the blood pressure is not getting controlled in the individuals even after trying the other drugs. So in that case, we are going to add aprocitentan to the other antihypertensive treatment, that is other antihypertensive drugs which are already being given to the patients. Now coming to the dosage and administration. So the recommended dosage is 12.5 milligram given orally once daily. Whole tablets are to be given, and it can be given with or without food, that is in empty stomach or without or after having the food also. Then suppose if a dose is missed in a particular day, then we have to skip the missed dose and we should take the next dose at the regular time. Okay, and we should not take two doses on the same day. Suppose if we have missed a dose on a particular day, then the next day we should not take two tablets instead of one. So that is the point which is being mentioned here as per the US FDA guidelines. Now coming to the pregnancy testing in females of reproductive potential, that is before starting the treatment with aprocitentan and when the individual is on aprocitentan treatment. This is because aprocitentan is having fetal toxicity, that is embryo fetal toxicity effect. So whenever we are trying to initiate the treatment, so we initiate the treatment with aprocitentan in females of reproductive potential only after confirmation of a negative pregnancy test. That is, if the female is pregnant, then we will not start aprocitentan in that female. And also the patient should exclude pregnancy with negative pregnancy test monthly during the treatment with aprocitentan and 1 month even after the discontinuation of the treatment. So before starting the treatment, negative pregnancy test is required, and when the patient is on treatment, then monthly they have to do the pregnancy test and it has to become negative. And after stopping the therapy also for next 1 month, the patient should have negative pregnancy test. And so that's why the contraindication for the use of aprocitentan is pregnancy and hypersensitivity. That is basically if we get a hypersensitivity reaction from the previous use of aprocitentan, then we are not going to use aprocitentan in the further episodes. So this is about the pregnancy testing in females of reproductive potential and the different contraindications. Now coming to the warnings, precautions and ADRs associated with aprocitentan. So first I have already mentioned, that is embryo fetal toxicity. That is, if pregnancy is detected and the individual is on aprocitentan, then we have to immediately discontinue the aprocitentan. That is the reason why aprocitentan is available only through a restricted program under REMS, that is risk evaluation and mitigation strategy, called Trivio REMS, because of its embryo fetal toxicity. Then other adverse effects which it causes is hepatotoxicity, which is seen in the form of elevation of aminotransperases. So this is the reason why even before starting aprocitentan we need to do the liver function test, and if the aminotransferase levels are coming more than the 3 times of the upper limit of the normal, then in that case also we cannot start aprocitentan. And if the patient is on aprocitentan and the patient develops symptoms like nausea, then we have vomiting, abdominal pain, then pruritus, basically itching, like all the symptoms which are pertaining to damage to the liver, in that case immediately we have to stop the treatment with aprocitentan. Then aprocitentan also cause fluid retention, and as a result it can lead to peripheral edema, it can lead to weight gain, it can also lead to heart failure because it is going to cause fluid retention. Then it can also cause hemoglobin decrease. So this is the reason why even before starting aprocitentan we need to do a complete blood count. If the hemoglobin is less and we find that the individual is having severe anemia, then in that case we cannot start aprocitentan in that individual. Then decreased sperm count is one of the adverse effects. So whenever we are giving aprocitentan to a male individual, we need to counsel the male about its adverse effects and the chances of infertility which it possesses in case of males. So that is basically depicted by this image, as you can see here. So liver can get affected, that is hepatotoxicity, then decrease in the RBC count, as you can see, that is hemoglobin, then it can affect the embryo and the fetus, then it can affect the sperm count. So all these things are depicted in this picture, so you can see. So with this the adverse effects are done. So basically it can cause embryo fetal toxicity, then it can cause hepatotoxicity, then it can cause fluid retention, which can manifest in the form of heart failure, then in the form of peripheral edema, in the form of increase in the weight, that is weight gain, then decrease in the hemoglobin count, then decrease in the sperm counts. Now coming to the experience which we have gained from the clinical trials involving aprocitentan. So there was a trial, that is dual endothelin antagonist for resistant hypertension. That is the hypertension in which we have already tried three types of antihypertensives, in which one is a diuretic and still there is no control of the blood pressure. A multi-center blinded randomized parallel group phase 3 trial for aprocitentan. So what was found in this? So the safety of review, that is aprocitentan, was evaluated in this placebo-controlled phase 3 clinical study in the adults with uncontrolled BP, that is resistant hypertension, systolic blood pressure more than equal to 140 mmHg, despite the use of at least 3 antihypertensive medications. So that is basically there. And what was the interpretation? It was found in patients with resistant hypertension, aprocitentan was well tolerated and it was superior to placebo in lowering the blood pressure at week 4 with a sustained effect at week 40. So basically it helped in decreasing the blood pressure in case of resistant hypertension. So that was the result of this trial. Now coming to the other advances in the management of hypertension. So we have several other treatments which are based on the devices which are coming up nowadays, like we have renal denervation, then we have carotid baroreceptor stimulation, and then we have the moderator system. So moderator system, when this device is being activated, so then it will lead to the control of the systolic blood pressure, that is the 24-hour systolic blood pressure gets reduced, and this effect is maintained through 6 months. So basically decrease in the 24-hour systolic blood pressure for next 6 months. So that is what we achieve by the activation of this device that is called as the moderator system. However, on the long term, consequences of this cardiac neuromodulation, so basically all these devices work on the principle of cardiac neuromodulation. Their efficacy and effectiveness in the long term is yet to be confirmed with the help of some of the trials on larger population. So now let's discuss one by one these newer strategies. So first we have the renal denervation. So renal denervation is a minimally invasive medical procedure which is used to manage hypertension, particularly in patients with resistant hypertension. So what is being done in this procedure actually? This procedure involves disrupting the renal sympathetic nerves to lower the blood pressure. So basically we are having 3 steps in this, that is catheter insertion, then energy delivery, and then nerve disruption. So what we are doing is basically from the femoral artery, from the femoral artery we are going to insert a catheter and it is going to reach the renal artery, and the renal artery is being surrounded by the sympathetic nerves. So then we are going to apply energy through this catheter in the form of ultrasound or radio frequency waves, and this will lead to the destruction of these sympathetic nerves around the renal artery. So this is what is called as nerve disruption, and as a result there will be no efferent and afferent output to the kidney. There is no impulses being carried out from the renal sympathetic nerves to the central nervous system, and there won't be any impulses which are reaching this sympathetic nerves, which you can see in this image. So when we are disrupting the renal sympathetic nerves, the afferent sympathetic activity is lost. So there will be inhibition of afferent sympathetic activity, which is manifested as decrease in the central sympathetic tone. So it leads to basically vasodilation. Then efferent sympathetic activity is also lost. So this will be manifesting in this following, that is there will be decrease in the renal vasoconstriction. Then there is decreased production of renin. So this indirectly leads to decrease in the sodium retention and water. So as a result, both this will lead to decrease in BP, because we are getting vasodilation plus we are also getting decrease in the sodium and water retention. So both this will lead to decrease in blood pressure. So indications of renal denervation therapy. So basically it is tried if the hypertension is not controlled by combinations of renin, angiotensin, aldosterone system blockers like ACE inhibitors, angiotensin receptor blockers, diuretics, and calcium channel blockers at their maximal tolerated doses. So basically resistant hypertension cases. And then if the individual is having essential hypertension stage 1 or 2, which is either untreated or not controlled with 1 to 2 drugs, in that case we are going to use renal denervation method. Now coming to the next method, that is carotid baroreceptor stimulation. So it is also known as baroreflex activation therapy, which is an advanced treatment for managing hypertension, particularly the resistant hypertension. So what is being done here is basically we are going to implant a pulse generator which is just below the right collarbone. As you can see here, right collarbone, that is clavicle, we are going to implant a pulse generator, and then it is going to stimulate the carotid bodies which are present in the carotid arteries. And whenever it is being stimulated, it seems that it is finding that there is an increase in the blood pressure, which is the normal phenomenon. So here we are going to replicate that normal phenomenon, that is the body is not going to stimulate these carotid baroreceptors, but the device which is implanted here through its electrodes, it is going to stimulate the carotid receptors, and as a result the carotid baroreceptor will find that there is an increase in the blood pressure. It will think that there is an increase in the blood pressure, and as a result there will be decrease in the blood pressure by the compensatory mechanism. So basically it is stimulating the baroreceptor reflex. So it results in lowering of the heart rate. That is, whenever there is increase in the blood pressure, we know by reflex there is reflex bradycardia, so there is lowering of heart rate. Then there will be dilation of the blood vessels, reduction in the blood pressure due to decreased sympathetic tone, because blood vessels are dilated and there is decrease in the vascular resistance. So this method is indicated in case of resistant hypertension and when the individuals are intolerant to antihypertensive medications. So what are the benefits of using carotid baroreceptor stimulation? So it causes effective blood pressure reduction. That is one important thing. Next, it is a non-pharmacological approach, so there is no chance of adverse effects which are seen with the drugs. Then coming to the risk, since it is a surgical procedure, that is we need to implant a device, so it carries some of the surgical risk like infection, bleeding, then trauma to the nerves surrounding that particular area. So these are some of the surgical risks. Then some of the issues which are related to the device, that is device related issues like malfunctioning of the device, then electrode dislodgement, then all these things can occur. That is the device related issues. Then we have the cost and availability problem, since this is a very expensive procedure, so not everyone can afford this, and also there is limited availability of this device. So these are some of the disadvantages of carotid baroreceptor stimulation. Then let's move on to the next system, that is the Moderato system. As you can see here, this is the device Moderato system. So it is a patented implantable cardiac stimulation based treatment for hypertension that immediately and substantially lowers the blood pressure. So here basically this device is going to control the functioning of both the chambers of the heart, that is atrium and ventricle. So the stimulation algorithms in this Moderato device are designed such that they simultaneously modulate the autonomic nervous system, okay, which is basically responsible for controlling the blood pressure and maintaining the blood pressure. So it is going to control this autonomic nervous system, plus it is also going to have the effect on the chambers of the heart, that is atrium and ventricle. That is, overall it decreases the blood pressure. So it is used because it is having an effective and sustained blood pressure reduction. Then again, it is a non-pharmacological action, so we will not see any adverse effects associated with the drugs. Then it is less invasive when compared to insertion of a pacemaker. Okay, so whenever we are introducing a pacemaker in the heart, it is comparatively less invasive than introduction of a pacemaker. And then coming to the risks, it is the same as that of carotid baroreceptor stimulation. That is, there are surgical risks like infection, bleeding, then trauma to the surrounding nerves, then device-related issues like electrode dislodgement, then device malfunction, then limited evidence of its efficacy and effectiveness in the management of hypertension. So all these are the disadvantages of the Moderato system. Now, finally coming to the conclusion. So from a therapeutic standpoint, currently we have many effective and well-tolerated antihypertensive medications, but a long way is still to go to do the optimal use of all these drugs either alone or in combination. So we need to make some strategies where we can use all these drugs together and in an efficient manner, and also the search for the new drugs needs to be continued, because we are having several ways by which hypertension occurs. Basically, the pathophysiology of hypertension is so huge, so that we have several targets for the new medications to act on. So these are the references. So with this, I would like to end this presentation. So I hope you like my presentation. If you like my content, please do like, share, subscribe, comment, and also press the bell icon so as to get notified whenever I upload a new video. Thank you guys.